Hello, welcome to the Cleveland Clinic ultrasound course. My name is Shah. I'm staff in radiology and nuclear medicine. I also have a director role in the School of Medicine. Our talk today will be on basics of diagnostic ultrasound. We're going to cover two topics. First, we're going to begin with the physics and probes and equipment, named waves, probes, and knobs, and then move on to techniques, scan, and artifacts to discuss patient positioning, image acquisition, and interpretation. Here are my sources for acknowledgement. So let's dive into it. We have scans, ultrasound scans from a 41-year-old male who was involved in a helicopter crash, getting a fast exam, sagittal view on your left, axial view on your right, demonstrating the liver. We can see right pleural effusion, perihepatic ascites, that's echogenic, and we see a laceration within the liver on the left-hand side. On the right-hand side, we see asymmetric thickening of the right rectus abdominis muscle without color flow within it, consistent with a hematoma. A scan like this belonged to none other than Kobe Bryant during the time of his demise. These are two images, apical four-chamber view and sub-xiphoid view of cardiac scan that was done on a 60-year-old female who complained of shortness of breath and had cardiac arrest while on a flight. She ended up subsequently getting this cardiac evaluation, demonstrating normal morphology of the chamber and intact walls of the ventricle. However, we see a pericardial effusion. Later, she succumbed to pericardial tamponade, none other than Carrie Fisher or Princess Leia of the Star Wars fame. This is an axial image obtained at the upper abdomen demonstrating a pancreatic mass, unresectable cancer on a 70-year-old male complaining of abdominal pain, weight loss, a scan like this belonging to none other than Mr. Jeopardy himself, Alex Trebek. And then closer to home, DVT study from right lower extremity groin ultrasound demonstrating a non-compressible echogenic thrombus within the femoral vein on an axial and post-compression axial view, none other than with subsequent PE demonstrating, PECT demonstrating large volume thrombus in the pulmonary arterial circulation of one of my neighbors. So if you think who's going to get an ultrasound at some point in their life, well, it doesn't matter. Maybe you're my neighbor, maybe you're a princess, maybe you're a movie star, politician, a super judge, princess of the galaxy, the queen of a country, a super athlete, or maybe even a superhero. Chances are you're going to get an ultrasound at some point to evaluate some abnormality. So we talk about ultrasound, we're specifically referring to medical sonography or medical ultrasound. It's important to understand who invented it, how does it work, when do I use it, where can I learn, and what are its applications. So let's do a little bit of a objective review. We'll start with a quick introduction of history and development of ultrasound, followed by a discussion of the physics and the equipment, discuss some scientific underpinnings of clinical sonography, the knobology, image acquisition, optimization, and so forth. And then we'll actually dive into the techniques of scanning with patient positioning, scan technique, acquisition of the image interpretation, and recognizing a few important artifacts along the way that give us diagnostic clue to the pathology. We will review at the end with doing some clinical vignettes that actually summarize all of these important points. So we begin with the introduction of Lorenzo Spallanzani. This is a priest by the day, if you will, a physiologist and anatomist by the night, who in 1974 hypothesized that bats navigated in the dark and hunted in the dark with a shrill of a voice from their voice box, the echolocation then determined by hearing rebounding sound from that. The father of sound, I suppose, or the ultrasound. Fast forward to nearly 100 years, Paul and Pierre Curie discovered and described the piezoelectric effect. Now, basically, their work focused on discovery of crystals or salts that were able to generate sound waves or mechanical stress when induced with electricity, and then conversely so, that when you applied electricity, they were able to convert that into mechanical stress or sound waves. For this, they won the physics prize in 1903. This was subsequently followed by a sentinel application of ultrasound outside the lab with development of sonar to detect icebergs and submarines in World War II following sinking of the Titanic in 1912. This technology matured and actually came out of sort of warfare, and then eventually ended up in scientists and physician labs between 1950 and 1970 This is when clinical sonography or ultrasound came into being for evaluation of gallstones or abdominal masses or pelvic female bleeding and assessment of blood flow within heart and vessels. So fast forward to 2025, what is clinical sonography today? Well, it is one of the most versatile medical tools that are around. It comes in a variety of sizes and configuration, as you can see, useful in a variety of settings. We have the handheld ones or mini ones that can open up in a palm, typically used in the field in setting of deceleration injury or perhaps in the emergency room. We have scanners that are slightly larger that can be used in the outpatient setting for evaluation of thyroids and bladders. We have even larger standing units that can be used in the ICU to not only diagnose hypotension and fluid status, but do procedures. And then we have larger ones in cardiovascular lab. Of course, in our own radiology department, we have very nice freestanding units. And then we have sort of medium-sized units that we use in the OR to help ablate liver tumors or renal masses. So quite extensive in quite a variety of settings. It's important to understand why we see this proliferation of ultrasound. It's number one, it's extremely portable given the small sizes. It's readily accessible. Compared to other imaging modalities, it's very inexpensive and relatively easy to learn to operate. Most importantly, it is non-invasive and has a very good safety profile because it does not use any ionizing radiation, unlike CT and X-ray. There are, however, limitations that we should be aware of. Number one is patient habitus. Number two is limited scan window. This is particularly important in the inpatient setting when you have bandaging or when you have postoperative patients with staples and so forth. So it can be limited by that. It can also be limited by, naturally, by air, by bone, by cloth, any sort of cloth or bandaging material, as well as metal, due to their high acoustic impedance properties, not able to penetrate those things. The most important one we should walk away, and it's an opportunity for us here, is that it is limited by operator expertise. And this is what brings you here to this course. So who uses ultrasound? What are its current clinical applications? Well, it's like trying to answer what are the uses of a duct tape. You know, it's numerous and too many to count and always evolving. I certainly use it as a radiologist for screening, for surveillance, and for doing biopsies and making diagnosis as part of my toolkit. A critical care nurse or a physician may use it to assess fluid status using a rush protocol or to assess for DVT, to look for deep venous thrombosis in legs. And OB or OBGYN may utilize it in their office in outpatient setting to assess pelvic plane or dysfunctional uterine bleeding or to manage pregnancy. Perhaps a cardiologist would use it to study dynamic movement of the heart, to assess its motion, to assess ejection fraction and so forth. Perhaps a surgeon who uses it to plan for ablation of tumors as they need. Perhaps first provider uses it in an ambulance to assess for critical findings of pericardial effusion or ascites in a trauma patient. Perhaps one of my physician assistant uses it to do paracentesis, thoracentesis, or use it as a guidance tool for that. Perhaps one of my outpatient physician colleagues uses it to assess the thyroid in that setting or to look at the urinary bladder or the kidneys for hydronephrosis or suspected infection or hydros. Perhaps my anesthesia colleagues uses it for epidural pain injection or for pain control in the MSK setting by their team. Or perhaps my emergency medicine colleague uses it not only to do a quick assessment in a critically ill trauma patient, but to do potentially a pericardiocentesis as shown here. So vast number of uses, vast number of settings. Before we move on to into clinical sonography and take that deep dive, it's important to understand some physics and some component of how this has happened. How do we go from sound waves to actually creating image? We have to start with clinical sonography actually. What is clinical sonography? It uses high frequency sound waves to generate those clinical images, and we've seen that using transducers. But let's back up one thing. What is sound? Sound essentially is currency of sound is sound waves, right? It's a mechanical disturbance that is produced in a certain medium and travels through that medium. And when we hear it in the air, we hear it as an audible sound wave in certain frequencies. As you can see in the graph below, our audible frequencies range in humans from 20 to about 20,000 hertz or 20 kilohertz. Clinical ultrasound uses higher frequency sound waves to penetrate soft tissues of the human and non-human bodies. I guess veterinarians use it as well, in the range of 2 megahertz, so 200,000 to 400,000 to 1,800,000 hertz. And so they use this to penetrate that body, and depending upon the reflective properties and acoustic impedance properties of viscera inside the human body, we're able to make diagnostic images using those acoustic properties. So again, we're in the megahertz range when it comes to clinical sonography. All right, well, we've talked about understanding of sound waves. How do we go actually from waves to creating that image? So there's a beautiful interface of having a computer and a transducer that we have to talk about that allows us to take that wave, convert it into that image. Irrespective of any ultrasound, you're going to have 4 basic parts to any ultrasound unit, whether they're handheld, portable, or mobile. They will have to have a display monitor of sorts. Some of the newer handheld units have it sort of in the palm of your hand, like a phone or so forth you can plug in, or an iPad, but you must need a display monitor. You would also need a PC with a CPU in it for the software, for the power source, and to store images and so forth. The most important part of any ultrasound units, however, arguably, are the use of transducer or probes that contain those piezoelectric crystals that those 2 gentlemen discovered. These are used to obtain images, and then various controls and knobs that help you optimize and annotate those images. Very important part of ultrasound equipment. Let's do a deep dive a little bit into the probes. Well, what are probes made of? Probes are basically transducers that contain those piezoelectric crystals. These crystals, again, have that ability to generate mechanical sound waves in response to electrical stimulus or electrical charge. And remember, this is a reversible property that these crystals have. If you give it electricity, it forms waves. If you give waves, it can convert it into electricity. Some of the newer systems have more IT-based solutions, semiconductor electromechanical systems that use vibrational energy to create a similar effect. So let's take a look at a cutaway of a transducer or a probe. We see now a cutaway. We see the wire coming in from the top. We also see the piezoelectric ceramic crystal or element at the bottom. And we can see that this blue part is where those are housed in an array or an arrangement. All right, they can be in a linear fashion, a rounded fashion, and we'll see some examples of that. When electricity is passed through the cable and excites those elements, that transforms that electricity into mechanical sound waves. These acoustic pulses are then transmitted through the human body in the shape of a thin beam right into the body. Now, we use a gel as a medium to help keep the robustness of that sound wave as it enters the human body. These waves then, depending upon the reflective surfaces and acoustic impedance properties of tissues, will be absorbed, reflected, refracted, transmitted, scattered, etc., based on those properties. And we'll do a little deep dive coming up into one of the slides on this property. In any case, the waves that are then returned right to those piezoelectric crystal, reflected or refracted back, that then is converted into that mechanical energy converted back into electric signals. Then doing a complex computer analysis and software processing, and ultrasound image is formed. That's sort of the overview, going from crystal to image. When we look at that particular property of sound waves that it relates to soft tissue, there's a very important property that all of our soft tissues have called acoustic impedance. And acoustic impedance is the ability of that soft tissue to interact with that sound waves. So we have 3 transducers at the upper left side. We have 3 different viscera or soft tissue structures down below, namely the bone, the liver, and the cyst. And we're scanning them. So acoustic pulses pass from those probes through the subcutaneous soft tissue into those various 3 tissues. What happens at the level of the bone, because bone has a very high acoustic impedance, most of the sound waves are reflected back, and nearly all of them come back, and we really lose the penetration of soft tissue deep to bones. When you look at a simple cyst containing simple fluid, those beams essentially completely pass through that cystic structure. There's no stopping of them. They go right through them. There's high degree of transmission because water or fluid has a very small acoustic impedance. So again, through transmission. Everything else falls a little bit in the middle when you have the liver, the thyroid, the heart, and other complex soft tissue structures that either absorb, transmit, reflect, or refract the sound waves, and depending upon its composition, depending upon its density or acoustic impedance properties, we get various gray signals right in the middle of those 2. Why do we use ultrasound gel? Well, this is not the same kind of gel that we apply to the hair and things like that. This is a very specific kind of medical gel because the property of this thick gel is to reduce or actually to improve the contact of the transducer with the human body. Here is an image on the left upper side, a sagittal view of the liver that is done without gel. And you can see while some of the images you can get a nice beam penetration into the body, other areas where there is relatively poor contact and more air, you have just blackness and darkness. You just don't have good penetration. By using ultrasound medical grade gel, which is a thick, sticky compound made of polypropylene or propylene and water, it essentially takes away the layer of skin. It improves that contact for a better beam penetration and transmission, and you acquire a much better image. So it's sort of a quality thing. I often get asked, can you use other substances in emergency? I suppose you can, but we always advocate the use of medical grade gel for this. Probes. Probes, like flowers, come in all sorts of size, shapes, and different than flowers, frequencies, and footprints. What you see on your left-hand side is almost like a bouquet of transducers. You can see some are big, some are small, some are tall, some are short. The images on the right demonstrate they're varying in frequencies. The probe on the left, 1 to 4 megahertz frequency, as high as 14 megahertz frequency. And notice the footprint. Some of them are curved, some of them are flat and linear, some of them are small, some of them are larger. They each have their function. I do want to take a take-home point here that the frequency on that transducer that is indicated on each transducer is inversely proportional to how well it can penetrate into the body and directly proportional to the resolution. Again, smaller, the higher the frequency, the poorer the penetration, but the better the resolution. And we'll review that a couple of more times. What are the common probes that we're going to use? We're going to use these three ones most 90% of the time. There are other specialized ones that are for prostate and for looking at lumbricals or for small, very small structures in the pelvis, and of course transvaginal scan for endocavitary scanning in females. But the first one I want you to pay attention is the scanning surface. The first one, the green one, is curved. The second one is kind of flat. The third one is essentially flat with a little bit of a curve to it. When you look at the first curved transducer, these tend to be 2 to 6 megahertz in their frequency, so relatively low frequency. They're large, have that curved surface. They offer a very wide field of view, so you can see a lot of things on that one single scan. Deep penetration, good central focus, maybe poor at the periphery, but a very good central focus. Typically used in abdominal applications where you have a lot of soft tissue to penetrate, for the assessment of liver, for example, gallbladder, looking at aorta for aneurysms, and for procedure guidance. The second one outlined in blue is our linear transducer or probe, typically 9 to 14 megahertz. That's relatively high frequency transducer, medium size, flat surface, small field of view, very uniform beam, almost like a rectangular beam that comes out. Very useful for superficial and small pathologies such as skin, such as thyroid, urinary bladder, or looking at muscle or tendons, musculoskeletal, and certain superficial vessels like DVT study. The third is called a phased array or vector. This is sort of a 4 to 5 megahertz transducer, low to moderate. What is interesting, it has a very small, flat footprint, so it's able to penetrate those difficult positions such as between ribs. It has a narrow beam. It's interestingly has a high frame to rates per second, so very good for structures that are moving, like the heart. It penetrates relatively well deeply, has good central focus. Again, not great near field view, but very good deep focus and good central focus. Very useful for cardiac due to a small footprint and often for procedures. So these are the three we're going to actually focus on. An important part of basic ultrasound is to understand how to hold a probe. Now, when I teach my students, they vary all over the place. Some hold a wire, some hold it very loosely, some hold it like a hammer. I think the best way to hold it is firmly, like a 4-finger grip baseball. So I think I want you to hold it on either side along the curved edges, just like it is shown, and it'll give you the best contact. It requires a little bit of pressing into the human body, so don't just place it superficially. Give it a little bit of a push, until the patient says, oh, that is hurting or something, you can back off. But it does require a little bit of good contact with that gel. The other thing is orientation of the probe. Each transducer or probe will have a long notch on one side and a short notch. The image to our left demonstrates a long notch one with a small red dot. By convention, these long notches and red dots are always oriented towards the patient's right. They're always oriented to the patient's right, or when you rotate the transducers to the patient's head. So this is by convention. It could be reversed, but most machines and most people who scans try to keep those two structures of the patient right for orientation. It's important to understand, briefly review our planes, and I think we're all used to it, but perhaps as an imager I'm used to it, perhaps as a clinician you may not be, so I want to cover this. Main three scans that we take in the human body. The first one is the coronal plane, that is in the purple transparent box with the purple lining. These planes go from the front to the back and parallel to the long axis. They start at my nose and go all the way towards my scalp and then my head. Transverse or axial is exemplified by the green marginated rectangle there. This separates the top from the bottom, so an axial scan actually goes from the top of my head down through my face and down through my chin into the mandible and the sternum. These are also perpendicular to the long axis of the body, but again goes top to bottom. And then sagittal, similar to coronal, it is parallel to the long axis, but it's side to side, so it goes left side to right side or right side to left side. These are three basic planes that we're going to be scanning in, and it's important to understand. The oblique plane is done understanding that there are structures in the human body that are not completely round, ovoid, rectangular, triangular, that they are obliquely oriented like the portal vein, and that requires a certain bit of obliquity and a combination of all of those three fields. Now that we understand the planes, we have to talk about maneuvering. This is an important thing to orient you. So when you place a probe, like in this patient, it's placed above the level of the umbilicus in a transverse or short axis plane, the part that says ANT, and this is of the liver. So we're looking at the liver. The part that is closest to this transducer is at the 12 o'clock position, or says anterior. The part of the scan that is the deepest to the transducer towards her spine is labeled posteriorly. So again, that's at 6 o'clock. The stuff closest to the transducer, 12 o'clock. By convention, we have that long notch to the patient's right or our left. And so our left becomes the right, it's a switch. So that to our left is the patient's right, and to our left is the patient's right, and to our right is the patient's left. So it's a reverse mirror image. And you'll figure this out very simply when you begin scanning. When you rotate the transducer by 90 degrees, remember the red dot goes towards the patient's head. So go clockwise, rotate it 90 degrees. The image, that part of the image that's closest to the transducer is always at the 12 o'clock position, named anterior abdomen. The part of the image that goes towards the spine is posterior, or at the 6 o'clock position, right? So we see the diaphragm as this echogenic structure over here. Now that we've turned, we still see the liver. The anterior part is the closest to this transducer. The posterior part is deep way down here. And because we've turned it by convention, the red dot is here, that points to the patient's head, and this page to the patient's feet. So the feet are here, the head is here. That's important to understand conceptually, but when you start scanning, it makes total sense. Maneuvering the transducer, you might hear some of the instructors say, slide the transducer or probe, rock it or rotate it. I want to review this quickly with you. Sliding merely refers to sliding it across the surface of the body. You take the gel with you and you kind of just scoop it up a little bit and you slide it somewhere else. You don't rotate it, you don't change the axis, you just slide it. Rotating refers to clockwise or counterclockwise rotation by 90 degrees, 180 degrees, etc. So that's what you're going to see. When someone says, go ahead and fan it or tilt it, you're actually tilting that probe along the long axis. And when someone says, I want you to rock the probe to get a better look at the gallbladder or something, you go along the short axis. Again, sliding, rotating, tilting, and rocking, important before you begin scanning. Last thing we want to discuss is patient position. Patient can be placed in supine position with them laying on their back with their face up, typically useful for lungs, heart and abdomen, pelvis, thyroid, carotid, stuff that is more anteriorly. When is the patient placed in prone position with their face lying down? Typically when you do kidney biopsies or when you are aspirating something or doing a procedure in the back part of the body or evaluating the posterior aspect of the liver and the spleen, which can be quite posterior in location. Commonly, patients are placed on the left or right lateral decubitus recumbent positions. And this is done to really mobilize structures because of the effect of gravity. So for example, if you're not able to see the gallbladder because it's sort of hidden away behind the right lobe of the liver, you can actually put them in left lateral decubitus position and it frees up the gallbladder. Similarly, you can do it for spleen or for kidney, and this is super useful when you're trying to detect ascites or free fluid in the acutely traumatic patient. The last position, typically done in ICU or in the inpatient setting, is semi-recumbent position. Often we use sitting position to do procedures like thoracentesis, but in this patient is either hunched over on a table or something like that, or you're accessing their back, or you're doing it in a semi-recumbent position because of that angulation, they're unable to move, or maybe doing a thyroid mass evaluation, looking at carotid arteries. So there are a variety of positions you can place them in, but these are the common ones I wanted to discuss with you. Pneumology, I think this is the last part of the first talk. I think it's important we understand some basic controls. Just like the cars out there, here's an example of a control panel from a car where you have 82 buttons. I don't know if you're going to be driving or you're going to be looking at these buttons and trying to heat up your seat or something. It can be extremely confusing, but large units have this. And then you have like a Tesla interface where you have like nothing, no knobs. Everything is menu driven. And unless you know the menu, it's going to take you a while to figure things out. So in the same way, we have ultrasound machines that are large, very specialized, that have keyboards, that have at least 20 knobs in them. You're going to have to orient yourself or ask to do this. On the other hand, you have also those portable units or maybe handheld units that have these sort of swipe controls or pinch in, pinch out controls. I recommend you get in touch with an applications person so you can actually take a good crash course in this. But let's still review some of the basic controls. We see two scans in front of us to exemplify the principle of frequency. We see an axial or transverse view through the thyroid, demonstrating the left lobe of the thyroid, and you can see the carotid and jugular, common carotid artery and jugular vein next to it, and you can see that echogenic area right in the center is going to be the left lobe of the thyroid gland here. Here's the trachea with the shadowing from the air, because it's not penetrating. On figure B, we see a transital view of the liver. You can see the echogenic diaphragm. You can see the IVC, hepatic veins draining into it, some portal veins. And I want you to see this because this is a very superficial structure. This is a deep structure. So if I had to give you a chance, would you, one, use a 4 megahertz curved transducer to do figure 1 or figure 2? And where would you match up a 14 megahertz transducer, which is that linear, flat, high-frequency transducer? And I'm going to give you 5 seconds. 4, 3, 2, 1, and 0 to commit. And if you said that, hey, that's a thyroid, that's a superficial organ, I'm going to need high resolution, I'm going to use the high frequency linear transducer, you're absolutely right. This requires shallow penetration, really fine look at the thyroid, and you can actually see small of the arteries and veins that penetrate the thyroid. You can actually see the overlying muscle, the scalene muscle, sternocleidomastoid muscle with the intramuscular septae that go, the connective tissue that go. You can actually see the esophagus and the layers of the esophagus on the left-hand side, the artery and vein. Very fine, exquisite definition. Compared to that, for the liver, you're going to use a lower resolution, lower frequency transducer for deeper penetration. You don't need necessarily, unless you have an abscess or something you're looking here, you don't necessarily need to have any deeper penetration. It'll give you a good overview of the liver. Again, high frequency transducer, proportional to high resolution and lower penetration, whereas a low frequency transducer proportional to lower resolution, but higher penetration. Important point to understand. Just to drive that point home, we are looking at right upper quadrant view of the gallbladder, same patient, approximately the same time, using 3 different transducer. Low frequency transducer, again, deeper penetration, not that great of an image. When you come to the higher frequency transducer, linear, you can see actually the wall or the mirror of the gallbladder. You can see a little bit of sludge, maybe small polyps that are just not visible on these lower frequency transducer. Again, it really matters the depth of penetration, and it really matters what you're trying to evaluate and what is the task at hand. So again, frequency is proportional to the resolution, inversely proportional to the penetration. I want you to remember that. After frequency, it's important to understand gain. This is something you do as you're starting to scan. It refers to the overall brightness, and I think because of cell phones, we're familiar with a bright image. If you're trying to brighten up an image. There are controls on the phones that allow us to brighten up that image. TGC, I'll touch on it. It's basically an automated gain adjustment for multiple depths that comes in some of the newer units. But here's an example, a nice example of a sagittal or axial view through the liver. You can see the diaphragm, again, IVC, portal vein, kind of coursing by. You can actually even see the small little biliary tree. You can see the bile ducts here kind of hanging out. This is a pretty decent image. When you turn up the gain or turn down the gain, you kind of lose some of that information. So again, you want to adjust it to sort of the Goldilocks setting where you're comfortable, you can see the area that you're trying to see. Too high or too low of a gain will distort that image and it won't be as productive. After gain and frequency, we go to depth. When you look at an ultrasound image, you're always going to see these sort of little markings. These refer to centimeters. Maybe this is a 5 centimeter marker here, and then the 0, 5 centimeter, and 10 centimeter. This is obtained in the mid-abdomen at the level of 10 centimeter. It's pretty adequate for what we're trying to assess. This is a thin patient. You have the rectus abdominis muscle with overlying skin and subcutaneous tissue. You have the greater omentum. You have the left lobe of the liver, segment 2 and 3, falciform ligament coming down. You see the splenic vein coming across in the portosplenic confluence, superior mesenteric artery, aorta, IVC, pretty nice view. And here's the pancreas tail coming into the body. Here's the pancreas head and the Uncinate process. Very nicely seen. In the same patient, if I turn up the depth to 16 centimeters, you're going to struggle a little bit to see these areas. Why? Because you have this unnecessary landscape over here. You have the vertebral body with everything shadowing behind it because it's bone and the sun will penetrate. Psoas muscle or paraspinal muscles on the left side, psoas and paraspinal muscles on the right. Not a great modality to look at the retroperitoneum. So again, adjust the depth once you decide on the frequency and the gain. And the last is the focal zone. This is worth mentioning. This is where when you generate a sound beam, depending upon if it's linear or curved and if it's phased array or not, those beams can actually cross. And where they cross, there is a point where they cross and the point is the narrowest and the definition is the sharpest. This is called the focal zone. This is where you want your main area of pathology to be evaluated once you identify the pathology. You want to put the focal zone in that area. Again, there are units with multiple focal zones not available, but that'll come at the cost of temporal resolution. I want you to learn to set it at the area of pathology or the structure that you're trying to evaluate. At or just below it will give you the best definition. So here's an example. Here's 2 views of the liver, same patient, same time. You can see that the focal zone is up higher, so you can see actually a better image anteriorly. Remember, here's the transducer. This is the part that's the closest to the human body, and you can see a nice left of the liver here, whereas you kind of lose information down here. It's kind of darker, and it's not because there's no good contact or anything like that. It's just because the focal zone is set here, so the sharpest definition is here. On the other hand, if you're looking at a pathology that's deeper down, let's say in this part of the liver, you wouldn't put the focal zone way down here. So this part of the liver is very nicely demonstrated, and you can see the echotexture really nicely there. So again, adjust that focal zone. In conclusion, for this first part, we looked at probe selection, we looked at image optimization, we talked about knobology, and all these 3 things will help us make that accurate diagnosis. Before you scan, I want you to think about what you're scanning for. Think about the task at hand. Are you looking for a superficial or a deep structure in the body? Are you looking for better penetration or broader bandwidth? Are you looking for higher resolution? And based on that, you consider then the limitations of that patient, the patient's habitus, the position, the access to a scan window, whether they're a very large patient and have a small intercostal space or they have bandaging from recent surgery. So consider those. Based on that, I want you to pick a transducer or a probe with the optimal frequency. That's step 1, picking the right probe. Once you start scanning, which we'll get into, then you can adjust the depth, the gain, and the focal zone that we've just discussed. Just a reminder, frequency proportional to resolution, inversely proportional to the penetration. That is it. That brings us to the end of our talk. My name is Dr. Shah. I'm happy to entertain any questions. And thank you in the meantime for your kind attention.